Bismillahirrahmanirrahim. We start our day with the recitation of Holy Quran. Wal as Bismillahirrahmanirrahim. Wal asri innal insana lafi khusr illa allazina amanu wa amilus salihati wa tawasaw bil haqqi wa tawasaw bis sabr. Hopefully this remains a smooth journey. May I invite Dr. Nadeem Sadiqi, who is the moderator of the first session, which is Venous. So can you take chair? Thank you.
Assalamu alaikum and a very good morning to everyone. First of all, it is my absolute pleasure to welcome you all on this very first PAKVESCON, and we really hope that it remains a success and we organize and attend many more. So we start with the proceedings for today, and today the first session is on the venous and lymphatic disorders. And before inviting the elite panel of chairs, I would just like to state some rules, or I would say some things which probably we are going to follow for the next 2 days. And I'm sure every moderator will emphasize on that. All the presenters are requested to please stay within the allocated time, which is approximately 13 to 40 minutes. 1 minute is for the transfer and transition of the presenter. All the question and answers will be catered and answered by at the end of the session. So in between the presentations, we will not take any questions. For the presenters, at 12 minutes, moderator is gonna show you a card that only 2 or 3 minutes are left, so that you can start wrapping up your presentation. And also the chairs will also controlling the time management. With this, I would like to formally start this session. And it is my pleasure to invite Dr. Kamal Yusuf, who is one of the very senior vascular surgeon at Liaquat National Hospital, Pakistan, Karachi, and he is one of the chair. Second chair for this session is Dr. Suhail Choski, who is our esteemed guest from UK, consultant vascular surgeon at Colchester Hospital, and we are really delighted to have you here, sir. Please join the stage. And third chair for this session is Dr. Umar Hassan, who has worked hard for this conference, and he is a vascular surgeon at Shifa Hospital. So with this, I would like to hand over to the chairs to conduct this session, and thank you everyone for being on time.
Dr. Abdullah Saeed to present his presentation is a thrombolysis and iliofemoral DVT and evidence and technique. So, Dr. Abdullah Saeed, please.
Assalamu alaikum. Bismillahirrahmanirrahim. Okay, my talk today is mainly focusing on acute iliofemoral DVTs. So DVT, as we all know, has got a huge toll on the health services all across the world. I mean, this is just a brief overview of the venous anatomy, and it becomes important when we are trying to select patients in terms of who are the good candidates for acute DVT, thrombolysis, or thrombectomy. Main thing is, I mean, what we see is obviously there are two sets of patients who will have iliofemoral DVTs. One is where there is either a venous stenosis, or they have got a prothrombotic condition, or they have got a combination of problems. And the May-Turner syndrome has obviously become a reality in the last few years. Before that, I think there were not many believers of that. In terms of clot location, you can have iliofemoral, common femoral, IVC, or combination of the above. So it's the iliofemoral component that we are focusing today. Talking about the pathophysiology, ambulatory venous hypertension results in chronic venous disease or post-thrombotic syndrome. Post-thrombotic syndrome can have got a variety of conditions, but ultimately they require, they develop venous ulcers, and they are quite difficult to treat. So aim of this talk today is to focus on clearing that clot in the acute phase, so we can prevent post-thrombotic syndromes. Sorry, this is not working.
So, Abdullah, we know iliofemoral DVT is quite common and it is a very serious problem. So, what is the indication when you do thrombolysis, and what is your protocol? I have heard a lot good stories about you to develop a service in UK. So, how you were selecting the patients and how you were excluding those patients? Any thoughts?
I think what the patient selection is the main thing that we have to consider, because you do want to do it for the right patients. Not every DVT will require venous thrombolysis, and not every DVT will require stenting. Patients, I mean, obviously, if we can move forward with this, patients who develop ascending DVT, which is coming from the femoropopliteal segment, with no outflow obstruction, you can probably treat with the anticoagulation. When there is an outflow obstruction, because it's a single venous outflow for the limb and the common iliac vein, when you those patients, as the Kevin study from Norwich demonstrated, that 80% of them do not recanalize with anticoagulation, as compared to 80% of the femoropopliteal DVTs with anticoagulation will recanalize over time. I mean, they may not look pretty, but they will work. And patients are not symptomatic. So it's the patients that we have to treat. And obviously it's the PTS that it's the patients who develop more PTS. Okay, fine. So obviously, I mean, you guys are vascular surgeons, you know about the sequelae of the chronic DVTs. I'm not going to bore you with this. So initial question is, which DVT patients benefit from this clot removal? Exactly what Dr. Zia asked me. So probably all, but obviously it is expensive. It has got its risks. As the ATTRACT trial demonstrated as well, that it was mainly the iliofemoral segment patients which benefited more. And that's the point I was making, that the 80% do not recanalize at 5 years, as compared to femoropopliteal will recanalize in about 6 months' time. So why these patients? Because it's a single outflow. They develop the most severe post-thrombotic syndromes, and they have got a significant risk of recurrence. And some of the patients I'll show you later are the ones who have been treated conservatively first, and then represented with a DVT, and then they were treated and recanalized and stented afterwards. So because a lot of these patients are young, they have got quite a significant impact on the quality of life. Then there is a socioeconomic impact, devastating presentations with the limb. Some of these patients we see, even when we started, they will get referred to vascular surgery with the acute limb ischemia, and they will do a CT angiogram as a first thing in the A&E or emergency department. And we found out after looking at the CT, the arteries are fine, but it's actually the veins which are distended, and then they had the CT venograms, and then obviously treated accordingly. So it's important to recognize acute. Some of these patients do present with acute limbs, and conventional treatment has been working for a long time. It has got its benefits. But what it does is it prevents clot propagation, it prevents pulmonary emboli, and also gives moderate symptom relief. What it doesn't do is it does not resolve the clot. It does not reduce the risk of valvular damage and then the venous reflux. It does not prevent venous hypertension. And it does not resolve the symptoms quickly. So we know that a significant proportion of these patients from the published evidence do develop post-thrombotic syndrome. And those are the ones which we are targeting in terms of selecting those patients. So, I mean, that's a summary slide, basically different numbers, but it does demonstrate up to 50% of the time patients do develop post-thrombotic syndrome. NICE also commented in their recent guidelines that it is a limb salvage procedure, the DVT thrombolysis and thrombectomy. Patients should be selected and looked after by a multidisciplinary team, which includes vascular surgeons, interventional radiologists, and obviously hematologists, because it's not just that we have stented the patient and that's not the end of it. They do need investigating for underlying prothrombotic causes and also treatment for those and a long-term anticoagulation. Most important thing that I've learned from experience is you have to figure out when the symptoms started, and the symptoms obviously the patients will present with leg swelling, but it's mainly the pain that comes with before the swelling. And we need to try and dig that out from the patient because it is important with the pharmacomechanical thrombectomy that we have. They will be they will need to be done only within 2 weeks. So, and then obviously it's the anatomical distribution. Sorry, it stopped working again. So acute DVT symptoms should be under 14 days. Subacute symptoms are 15 to 28, and then more than 28, we will class them as chronic for this. And most of them will have acute and chronic DVT. So this is the May-Turner syndrome diagram that the right common iliac artery compresses on the left common iliac vein against the bone, results in a fibrotic stricture. That stricture leads to stasis and then obviously DVT formation. Okay, so I'll just quickly show you some cases because I've been shown a card. I don't know if all of the time is taken in the talk or in the technical glitches, but I think the fun bit will be the cases. So this is a 23-year-old army officer who had an ankle trauma and had a conventional treatment for a month and then came to us. So this was the initial venogram. The first one obviously shows superficial femoral vein DVT. Then you can see the iliac vein is not too bad. Then we had a post-angiojet and a pulse spray, and then also CDT because it's more than 3 weeks. Opened up a bit, and then this is the final image. Again, there is some chronic clot, but there is some flow now. So obviously, operator experience, we learn with experience, and I'm not going to go through the details of these. I think the take-home points are location and the duration of the DVT. Kevin trial did demonstrate that the catheter-directed thrombolysis prevented post-thrombotic syndrome by keeping the long-term patency and preventing recurrent DVTs. However, there was a risk of bleeding from it. So pharmacomechanical thrombectomy, obviously reduces the TPA dose, allows us to do these in a single session. They do however, have got a risk of major bleed. There is a theoretical risk of hemolysis, and so we need to keep it to. We cannot keep doing that because of the risk of hemolysis. So we have. I mean, what we used to do was 5 minutes, and then give the patient a break, and then do more if required. I want to move to the cases, so time is running out. So these are the consoles that we have. I mean, my experience is mainly focused on Boston Scientific Angiojet, but we have used Penumbra, and now obviously NRE is taking everything with its storm. So these are the other devices, penumbra, the Enari clot reaver on the right, and this is a similar device, Vetex on the left side. CDT alone can fail if not, especially if it's long-term time. So you obviously see the clot on the first venogram. Then we have done some catheter-directed thrombolysis, and then post-angiojet you get a lot better clearance of the clot. So it's another professional golfer. Sorry, it's not doing it in the order I wanted it to, but clot in the common femoral and the iliac veins, and then, sorry, good clearance after. This is first one, and then you have got some clonic clot still left. And what you can see, I don't know if I don't have the pointer, that you can see a meta compression on the third image, and then post-plasty and stenting, you do get a good view afterwards. So this is a 27-year-old, history of left DVT. Most of them somehow come with a left DVT, and there is an occlusion post-anguli, post-CDT, and then post-stenting. You do get some chronic clot. You only clear the acute clot with this, but that you can obviously stent and push outside. How many times? So we do have got some chronic clot, but obviously it's outside the stent. It's not obstructing flow. So that's another 22 years old, 2 weeks history, initial venogram, and then post pulse spray, you get a lot more clearance and flow, and then obviously post stenting, you get good flow into the IVC. So this guy was unable to wear his prosthesis because of the DVT. He's 78 years old, quite thrombosed, and then you have got excellent flow afterwards. I am trying, sorry. So this one is another one where you can see the balloon. These are prone patients, that's why they look on the right, they are all left. You can see a balloon wasting, that's the meta and compression stricture, and then post-stenting you get a good flow. I mean, this is the IVUS, which is quite expensive but an excellent tool for assessing suitability for stenting. Again, this is post-stenting IVUS. You see a good flow afterwards. So this was a postpartum female, initially treated with anticoagulation, but symptoms did not resolve, and then we ended up doing thrombolysis and then stenting, and had really good relief afterwards. Sorry, it's repeating some of the slides. I don't know why. So I want to show you a couple of interesting cases. This one is a keen cyclist, probably a professional cyclist. I think 2019 I saw him. He came in initially diagnosed with a pelvic mass, and then then he was referred to vascular surgery and then to me. And this was actually an external iliac varix because he was pushing really hard with the cycling, and the whole thing was thrombosed, and then there was a common iliac vein occlusion. So that's the initial venogram. That's the catheter-directed thrombolysis because he came to us in 3 weeks' time. Remains occluded, access from above, and then once we've stented, that had a really good result. And now, I mean, I've last year when I was in UK, I have seen his duplex, and all his aneurysm has completely shrunken around the stent, and it remains patent 5 years down the line. So this gentleman, if you see, the whole thing is occluded, and I think that brings an important point. If you have got a deep femoral or profunda vein that's thrombosed, do not stent, because even if you have cleared with thrombolysis, because you do need inflow into the stent, and if you don't get good inflow, the stents are going to thrombose again. And so that if you want one key point from this, that is that if poor inflow, even if you have cleared the clot, do not stent, otherwise the stents won't work. So this chap had a spinal surgery, and he developed DVT after that, and that was a few years ago. Then he came to us with a repeat DVT. which we cleared with angiojet, and that's what we got. That's a chronic occlusion. This segment was cleared post-angiojet, and I was concerned that nail has gone through the vein. So we ruptured a couple of balloons on this nail, and then eventually we got a vein. And again, this one had an excellent result afterwards. This one as well still remains patent a few years down the line. So I think it's time to review our DVT guidelines. Mechanical thrombectomies are safe, and now with the new devices, I think 2 weeks is history. You can treat them up to 6 weeks with a mechanical thrombectomy. It shortens the hospital stay, it improves the quality of life, and it gives quick relief, and it prevents post-thrombotic syndrome. So that's my pathway that we developed. I'm sorry, it's not readable. So it's young patients who have got good life expectancy, who have got no contraindications to thrombolysis. They can be treated, and obviously they have to have good inflow. Patients who had a longer duration symptoms, we did CDT first and then went on to pharmacomechanical thrombectomies. And almost all patients required stenting. So if the patients which we didn't stent did not do well in the long term. So that was our protocol for catheter-directed thrombolysis in terms of heparin and TPA. And that's the kind of result you see. You get a leg like that, and the next morning after stenting, you get a leg like that. So it's a huge improvement. Patients are really thankful. They go home usually the next morning. And I think I have done probably one filter for these. Sorry, I did not touch on the filter side. Do not run to do filters on all these patients, because these May-Turner compressions are preventing the clot from propagating to lungs. So if there is no IVC clot, do not do filters. If there is IVC clot, then obviously you have to think of filters. I think the time is up, and we can go through the questions afterwards.
Thank you, Abdullah. It was a good presentation, and I'm sure we'll have some panel discussion afterwards. So the next presentation is by Dr. Rehman on venous thrombosis, an overview of latest guidelines.
Yeah, thank you, Abdullah. And that was very fantastic talk. I wish we will definitely discuss in between lunch and coffee break on this. My talk is just going along these lines. We are talking on the venous thrombosis, which is a very, very common problem and a huge burden. And we actually work in the welfare of the patient, but in different direction. There's lack of guidelines, there's lack of protocols. I see you have made a very good protocol. You have shown in your setup how it works. So maybe tomorrow we are sitting together to develop that protocols for our own patients and how to develop it up. I will just go through the latest guidelines, that is ESVS guidelines, which has been done. Suppose you get a patient who is young, he has a DVT, femoropopliteal DVT. So what is the guidelines say? So guidelines says that if the DVT is likely, you are going to get an ultrasound. Ultrasound is confirmed. You treat it with anticoagulation for 3 months. But if the DVT is equivocal, means you are doubtful. So the first line of investigation should be the D-dimers. And if it is still equivocal, you have to get CTV or MRV. And that will confirm the DVT. Then you have to treat the DVT either as a provoked or unprovoked. If it is provoked one, then you have to treat them for about 3 months and stop the anticoagulation. But if it is unprovoked, then you have to do the thrombophilia profile. But that is required not in all patients. That is required in 3 types of the patient, in which there is a family history of VTE, or first relative has, or you are having decision to stop the anticoagulation. You have to get the anti-phospholipid antibodies. This is very important. So, but in our practice, we see there's a lot of variability in our clinicians. Some clinicians are doing over-test, and sometimes underdiagnosed what is there. And I will go, this is the lacking part. We do not give the compression stocking at quite early. That can reduce the post-thrombotic syndrome. If we go to the ESVS guideline, they usually recommend using the Villalta score. And if the Villalta score is more than 5, they need continuous elastic compression stocking. And that is up to below knee. And that is to be wear after 2 years. And if it comes after about 6 months of follow-up, less than 4, then you can always stop it up. But start it earlier. This is the second message from the guidelines which we have. Third message is the medication. You have to be very knowledgeable about the pharmacomechanics. The medication we use direct on the coagulation pathway and on indirect on the coagulation pathway. This is the coagulation pathway, and we see direct medication which are acting. What are they? They are the apixaban, rivaroxaban on factor 10A. Then on HIT, heparin-induced thrombocytopenia, we have medication dabigatran, hirodin. These are very important medications you should be knowing. And there are indirect medication which works, like heparin, low molecular weight heparin, and these are there. And when to use them and when not to use them. We need a protocol for them so that their side effects can be decreased. This is very important. Abdullah has touched the using of pharmacomechanic therapy for iliofemoral DVT. If we go to the systemic reviews, there are 2 or 3 trials, randomized trial, which I say every vascular fellow should read it up. One is the ATTRACT trial, one is the CAVA trial, one is the Torpedo trial. And what they check, they compare the only anticoagulation with early thrombus removal. And what is the result? Does it decreases the post-thrombotic syndrome? The answer is yes. Early thrombus removal reduces the all type of post-thrombotic syndrome. Does it reduces the severe post-thrombotic syndrome? The systemic review shows that it does, as we see here. But what about the bleeding risks? Bleeding risk. If we go through these trials, we found that use of early thrombus removal is associated with higher bleeding risk, as you see here. The bleeding risk is higher in those patients who have early thrombus removal. So on these bases, the guidelines has been made that whenever you get a provoked or unprovoked iliofemoral DVT or proximal DVT, first thing you have to do is stratify these patients whether they are low risk, low to high risk, or extremely high risk for bleeding. If they are extremely high risk for bleeding, treatment is temporary IVC filter. And when this patient gets stabilized and the risk decreases to low risk, you have to give them the therapeutic anticoagulation. And the therapeutic anticoagulation you have always prefer DOACs over the low molecular weight heparin or vitamin K. But if the patient is low risk, as Dr. Abdullah has said, in a selected patient, it does decreases the risk of post-thrombotic syndrome. Those are the patients which may benefit from the early thrombus removal. And the guideline says, whatever modality, it depends upon the physician, which modality they are going to use it. And that decreases the risk of post-thrombotic syndrome. And very important, you have to give the compression on that earlier. And if the compression is given earlier, that helps to solve the problem. Can we go to the slides, please? And second thing which I wanted to tell, that we have to see that patient has post-thrombotic syndrome and they have the risk factor which are transient, which has permanent, or what type of the risk factor are there. We go through there. So, if the patient has uneven foot treatment, you have to stop the anticoagulation after 3 months. And then stopping the anticoagulation depends upon the minor transient risk factor or major transient risk factor. Same is the algorithm for the provoked DVT, proximal DVT, or iliofemoral DVT. So these needs special guidelines, special protocols, which patient needs will benefit and whom we have to give them up. This we need to discuss among ourselves and develop these protocols. Then very important, and the last I will touch, superficial thrombophlebitis. This is a common entity. The guidelines has been developed. So we have to identify whether get a duplex ultrasound, and if it shows DVT, treat it as a standard DVT patient. But if it only shows the superficial thrombophlebitis, then you have to identify how near is the thrombus near the saphenofemoral junction. If it is near the 3 centimeter or equal to 3 centimeter, these patients need standard anticoagulation. But if it is more than 3 centimeter and the vein segment which is involved is more than 5 centimeter, they need fundaperinox for 45 days. And then you have to re-evaluate them up. And if there is a recurrent thrombus, there is a role of endovenous thermal ablation. So these are some of the guidelines which are there. And I will say that this is a very important entity in which radiologist, vascular surgeon, hematologist, and even the general physician has to sit and do it up. Tomorrow we have a small task force in which we are going to discuss and develop our own guidelines, local guidelines, and work on that. Thank you.
Thank you, Dr. Zia, for giving nice presentation, saving minutes for us as well. I will ask Dr. Illyas Sadiq to come and give a presentation on recurrent varicose veins, how to prevent and treat. Thank you.
Good morning, everybody. First of all, I think I would like to congratulate all the organizers to arrange such a beautiful meeting for the Vascular Society. It's a startup, and hopefully will do better and better. And today I'm going to talk about a recurrent varicose veins, its understanding and management. And as we all know, it's a very common problem. Our learning objectives today are what are the varicose veins, what are the recurrent varicose veins, and how can we predict the recurrence before it happens, and how we can manage once it happens. We know the varicose veins has been known to mankind since the ancient times, and it affects at least 40% of the Western population to some degree, and I think it affects almost to the similar population in our Asian population as well, although we don't have any data for that. Venous system of the lower limb consists of superficial and deep veins. We are all aware of this anatomy. And the etiology we see in our clinics most of the time are usually the primary varicose veins, but we should be aware of the secondary causes as well, because to make the proper management plan, we need to know all these causes. Symptoms of the venous insufficiency could vary from mild leg pain, aching and cramping up to the obvious varicose veins and the skin changes and the ulcerations. Diagnosis, as we all know, depends upon the detailed history, clinical examination, and the investigation which we use most of the time is the simple duplex ultrasound. Now we have multiple treatment options for treating the varicose veins, starting from the conservative management up to the hybrid type of combination, different combinations of different treatment. We can join these treatments in different set of patients. Since 1998, we have a consensus definition for the recurrent varicose veins, which is the presence of varices in the lower limb previously operated for varices with or without adjuvant therapies. Now, in different studies, the incidence of recurrent varicose vein has been shown to be 20 to 60% after 5 years, which is quite significantly high. And this is an important study which shows the saphenofemoral ligation if you are opting for a surgical option, And saphenofemoral ligation with the blow-knee stripping has the least frequency of recurrence, while the standard Trendelenburg operation without stripping has the highest rate of recurrence. And if you look at the table on the left side, it shows the different causes of recurrence in different patients. And the most common cause is highlighted, which is inadequate assessment in the preoperative period of a DVT. So, I mean, we can sometimes miss the properly recanalized DVT and take those patients for treatment, and they are the ones which can cause the most recurrences. This meta-analysis of 20 different randomized trials which compared these two types of modalities, and it showed no difference of in the overall incidence of recurrence between these two modalities. But the pattern of causes of recurrence are quite different in different treatment modalities. Now, if you come to the causes of the recurrence, in our setup, the most common cause has been seen as an inadequate initial operation due to one or the other reason. But if you have done everything appropriately and treated the patient surgically, then neovascularization could be a significant cause. And if you treated the patient with an endovenous ablation, recanalization is the most common reason for the recurrence. And at the time of assessment, if there is a presence of a deep venous pathology in some sort, in an obstructive form or in an incompetence form, if that is missed, that can cause the recurrence as well. And sometimes we find the new sources of reflux after treating the patient, which can lead to the recurrences. How can we predict the recurrence? I mean, if we have the history of the venous obstruction at the time of assessment, or if we have the had the venous reflux at the time of assessment, and if the patient has the high BMI, it can lead to the recurrence, and interventionist experience is quite significant. Investigation-wise, as we all know, the most common investigation we use is the duplex ultrasound, and we need to do a detailed assessment. Further investigation we do only in a certain set of patients when we suspect the deep venous pathology. Indications are the same as for the primary varicose veins. There is no difference. And the treatment modality, different treatment modalities we use for different patients depending upon the cause of the recurrence. I think it's stuck. No, it's not moving. Okay. I'm going to share with you a few of our patients which has been treated at our center, and you'll see all sorts of different causes of recurrence in these patients. First case is a 32-year-old male patient who had a surgery done 10 years ago. On our own assessment, it showed a incompetent saphenofemoral junction, and on ultrasound, there was no evidence of ligation of saphenofemoral junction at all. And if you look at the incision on the left side of the screen, it's quite below the groin crease. And this patient, we opted for a radiofrequency ablation because the vein was quite straight. It's again stuck. So in this patient, this saphenofemoral junction was as clean as it could be in the primary varicose veins. So this patient was treated with an RFA. Second patient, 35 years old male who had a surgery done 5 years ago, and the duplex scan again showed the similar finding, incompetence at saphenofemoral junction, and there was no evidence of ligation of the saphenofemoral junction in this patient. And you can see the big scar in the groin below the inguinal crease. And as we knew, this saphenofemoral junction is quite higher than this skin incision. So we opted for surgical treatment for this patient, and when we went in, there was absolutely no sign of any scarring or any previous surgery at that level. Third patient, 33 years old, female patient who had a surgery done in 2022, and saphenofemoral junction was ligated in this patient, and the great saphenous vein was stripped. This patient showed a reflux in the small saphenous vein, which was going up into the thigh as a Gavkomini vein, and the reflux was coming from quite high up in the thigh. So we decided to treat this patient with a mechanico-chemical ablation after getting the CT venography, which was normal. So this patient was treated with the mechanico-chemical ablation. The fourth patient is 40 years old male patient who had a surgery done in Italy. This patient had the properly ligated saphenofemoral junction, and it showed only few incompetent perforators, and this patient was treated with the foam sclerotherapy. Fifth patient was 37 years old male patient who had a history of RTA 10 years ago, and he had a varicose vein surgery done by a general surgeon about a year ago. This patient on duplex scan showed few signs of DVT, so we asked for a CT venography in this patient, and which showed the picture like a May-Thurner syndrome, total occlusion of external and common iliac veins, and this patient is waiting for a venoplasty and stenting. How we can prevent these varicose veins? So there is no rocket science really in this, but we need to have the detailed history examination and the detailed duplex assessment by the operator, not the duplex assessment by anybody else. If you are operating yourself or you are treating yourself, you should be able to do the duplex scan yourself. And in that, you need to know the right source of the incompetence. You need to check for accessory great saphenous vein, accessory small saphenous vein, and a reversal of flow in the small saphenous vein, particularly if it's becoming a Gavkomini vein, because then the source of reversal could be higher than the popliteal fossa. And if you're going for a surgery, then you need to ligate the saphenofemoral junction properly along with all the tributaries, and you need to strip the great saphenous vein up to just below the knee. And you need to customize the treatment for every single patient rather than one bullet for every patient. In my personal opinion, in Pakistan, I think the most common cause of recurrence is the inadequate initial procedure. In summary, the recurrent varicose veins is a big socio-economical problem with an incidence of 17 to 60%. Accurate pre-operative assessment and planning decreases the incidence, and non-surgical thermal ablation procedures are the first-line treatment for recurrent varicose veins. Thank you.
Thank you, Illyas. Thank you, Illyas. It was a very good presentation on recurrent varicose veins, which we do come across quite frequently. Now I would like to invite Dr. Mamoon to the podium for his presentation on lymphedema, the role of plastic surgeons, microsurgical reconstruction. He's from Shifa International Hospital.
Assalamu alaikum ji, and very good morning to all of you. I'd like to congratulate the society for holding its first meeting. I'm reminded of the first meeting of the Pakistan Association of Plastic Surgeons. There were 15 people sitting in a hall, and there were 10 papers, so we would each get up, present our paper, and then clap for the others. The last meeting of our society, which I just attended in Karachi a few days ago, had sessions going over 4 days in 3 halls. So I think you will grow to that, but I think you should also cherish these initial meetings where everybody knows each other and there's a sense of camaraderie which you lose when the society becomes very big. I'm really honored to be here, and it's a privilege to present my very modest experience in microsurgical reconstruction for lymphedema. We're all disciples of Alexis Carrel, and it's interesting that whether you're repairing the aortic root or you're repairing a digital vessel, you practically use the same technique. Microvascular surgery is the technique of anastomosing small blood vessels, usually less than 2 millimeter in external diameter. And in most cases, you can use loops, or if the vessels are smaller, particularly in children, you can use the operating microscope as well. We use it very frequently for cases like this, like replants in a 5-year-old child. And you can anastomose the veins and arteries and the nerves, and you can expect reasonably good function. We also use it very frequently for free flaps, which is transferring a block of tissue from one part of the body to another, along with its artery and vein. This is a patient with a capillary malformation, and after excision, that's a radial forearm flap anastomosed to the vessels in the neck, and that's the post-operative view. Currently, the field that is really garnering a lot of attention in plastic surgery is the field of super microsurgery. And this is a technique of micro neurovascular anastomosis for vessels and single nerve fascicles, which are between 3 to 8 millimeters in external diameter. And you need special equipment, you need special sutures. I'm attempting super microsurgery with microsurgical instruments. We don't have 11O and 12O commonly here. We don't have the specialized equipment, but we're still trying to do those things. Lymphedema, most of you are very familiar, so I'm not going to go into a lot of detail about what it is. I'll just say that most of the early stages are frequently missed because it's just a bit of swelling, and overnight the patient gets better. When he walks about a bit in the morning, the swelling returns, and it's only when it is quite problematic and symptomatic that these patients will actually seek attention. And when they seek medical attention, it's a very circuitous route before they get to the right person. Many of them will first go to a general physician who will, give them something, maybe diurese them or something like that, try to get rid of the swelling, but eventually they will land up with the proper person. In the late stages, of course, it is unmistakable, and you will see the typical elephantiasis, you will see the thickened skin and the fibrosis, and the propensity for frequent ulceration and cellulitis. Two main causes, primary and secondary. Primary cases, Milroy's disease, in which there is a congenital absence of the lymphatics, and usually they get their first symptoms between 10 to 25 years of age. Secondary, it may be secondary to trauma, chronic infection like in filariasis, and recently we see quite a bit of it in patients who've had surgery for some sort of cancer. I do a lot of sarcoma work with the orthopedic surgeons, and many of our patients will develop lower limb lymphedema after they've had limb salvage. In the Western world, it is post treatment for breast cancer that gives rise to most of these cases. The International Society of Lymphology has a staging system which describes the various stages for lymphedema, and this is basically a clinical classification, and it depends on how the patients are presenting with various stages. It's a good classification to use to describe patients to, another colleague or another specialty. The MD Anderson staging system is more focused on post-cancer lymphedema, and particularly of the upper limb, which is one of the commonest problems that they face. This is Cheng's classification, and Cheng is one of the pioneers of super microsurgery, particularly lymphatic surgery, and he's pioneered the concept of lymphatico-venous shunting. And this is really the first time that we had a technique which addressed in a physiological way the problem that the patients were facing. All the other procedures like Charles and Condolian and Swiss roll and all those which you remember reading, most of them were looking at the problem purely from an anatomic point of view, but not from a physiological point of view. And his classification also suggests a management plan. And you can see that most of it is based on lymphoscintigraphy and grade 0, less than 10% difference between the two legs. Then there's stage 1, stage 2, and in the very severe, there's total occlusion, and he suggested what to do. So it's a useful classification to have. These are the stages 1 to 4 as we see them, and this is how we see many of our patients in our clinic. So by the time they come to the plastic surgeon, it's really, really gross. And there's very little you can do except do stage excisions and put skin grafts on it. This is another patient. And it is really that we get patients with early lymphedema. And these are the patients in which we can do the fancy stuff. And so we are trying to encourage more and more of our colleagues, particularly in general surgeon, to refer these patients to us early, because these patients can really have beneficial treatment which will serve them throughout their lives. There are many ways of imaging the lymphatics. You can do direct lymphography, indirect lymphography, and then you can use radionuclide scanning to image them. And it gives you various patterns of lymphedema. And these are very useful if you're trying to come up with the strategy on which is the best way to help a particular patient. The only thing we can use frequently is radionuclide. The problem with this is that the images that they give us are not really detailed enough for us to make any determination and to decide an operative course. Indocyanine green lymphangiography has totally transformed the way that the lymphatic system is studied. The great advantage is that you can do it intraoperatively, and you can immediately see where the dilated dermal lymphatics are, and you can make incisions right over those areas. You will always find a subcutaneous vein or venule nearby, and under the microscope, it's fairly straightforward to do the anastomosis. And experts in this field will usually do it under local anesthesia, and they'll do 3 or 4 lymphovenous anastomosis if they have this sort of facility. Just a little about the lymphopress pump. This is a great thing. It is a graduated pressure stocking, and patients even with really huge elephantiatic sort of legs will have a relief of their symptoms if they use it every day. It used to be very cheap. You could get it from Dubai for 25,000 rupees. Now it's much more expensive, but it's still worth having. And most people who work with the surgical aspect of lymphedema will have this thing available so that the patients can use it post-operatively, and many patients will decide to buy it so that they have long-standing relief. So a bit about the options for surgical therapy. Lymphovenous anastomosis, it's, as I said, minimally invasive, and it's performed in early stage lymphedema. And it requires a patent lymphatic vessel for it to work. So obviously, you can't use it when you have congenital absence of lymphatics. But if you have lymphatics which are dilated or which have high pressure, you can do it. Lymph node transfer, vascularized lymph node transfer is, the current flavor of the decade. And this is something which can really improve patients, both those who have congenital forms, whether it's post-traumatic or it's post-cancer, they can all benefit from the transfer of a vascularized lymph node. Liposuction is something we like to do a lot anyway in plastic surgery, and it has good applications in lymphedema, particularly in patients who have very bulky legs. So what you're trying to achieve is basically take out a lot of the fat so that the dermal lymphatics have a chance of getting some spontaneous anastomosis with the deeper lymphatics in the muscle and the fascia. And it's an adjunct to doing other procedures as well. The excisional procedures, something like this, what I like to do is I like to first harvest the skin graft from this very badly scarred leg. Rather than taking a skin graft from some other part of the body, you have a lot of overexpanded skin, and then you excise it. You try to preserve the superficial as well as the deep veins so that they don't develop venous problems later on, and then you simply skin graft them. It's not a pretty sight, so it'll get rid of that really huge leg, but cosmetically and sometimes even functionally, they have a lot of stiffness. There's a lot of scarring, so it's not a great thing. But for patients who can't even walk, this is something that enables them to go on with their daily activities. Non-excisional procedures, I've talked about lymphovenous anastomosis, vascularized lymph node transfer, and suction-assisted lipectomy or liposuction. And these are the mainstays of treatment for most other cases. Now, lymphovenous anastomosis, the jury is still out as, what's the best way of doing it, whether it's end-to-end or end-to-side, vein to lymphatic or lymphatic to vein. And everything seems to work to some extent, but you have to do multiple sites for it to really make a difference. This is what it looks like under the microscope. This is from one of our own cases. So we've injected the patent blue dye near where we want to do it, and the lymphatics are very well outlined, and it still looks very small. The external diameter is less than a millimeter, but under the microscope, I mean, with 10 times magnification, it's good enough to anastomose, and you would always find a suitable vein nearby. So here you can see the anastomosis completed, and you can see the post-op result on this side, and there's marked reduction in the amount of swelling. And this is another patient, very significant reduction. Now, the interesting thing is, a lot of plastic surgeons are doing vascularized lymph node transfer all over the world. Nobody actually knows how it works. You take 2 or 3 lymph nodes with the artery and vein, and you put them somewhere. How does it suddenly decrease the swelling of the whole limb? There are various theories about it. Some people suggest that they induce lymphogenesis, and there's more lymphatics produced in that area. Some people say that it induces a lymphatic pathway, and you have a high pressure pump because you're anastomosing it to one of the major lymph vessels, like say the posterior tibial. So when the lymph comes in that area, the artery pushes that through the vein, and so you create a bypass shunt over there. This was the commonest thing that people used for many years. They used a groin flap along with the nodes in the groin and used this superficial circumflex iliac artery and vein for the anastomosis. The problem is that many of these cases, in up to 30 to 40%, later developed low limb lymphedema. So this has gone into disrepute. This is now very popular using the supraclavicular nodes, and this is based, I can't actually see. Oh, right. I just have a few more slides to go anyway. So it's based on the transverse cervical artery and vein, but if you take some skin with it, you have to take the external jugular vein as well. So this is just a diagram of how we do it. So this is a patient with very significant low limb edema on the right side. Intraoperative, that's the harvest of the node and the skin. And you can see this is the skin pedal, which we use basically as a monitor. You don't need skin, but it's the only way to monitor whether the flap is working. And so there's significant improvement. And this is improvement which is sustained over the long term. So that's the important thing. It prevents the development of those really massive limbs. And it's just a scar over here, which actually heals quite well. Another patient with right-sided lymphedema. This is the lymph node dissection in progress. This is we plug it into the posterior tibial in most cases. And this is the post-operative improvement. You can see there's a very significant reduction in size here. And just a scar as a memento. Is there a perfect protocol of doing things? Even airline pilots get it wrong. Beware the silver tongue of the dogmatically certain. So you go to meetings and there are people who will say, you know, this is the way of doing it. And they're so persuasive, and you come back and the next 3 years, you know, you wish you were rotting in hell because of what you learned there. Clarity can only be born of experience. So pick up something, see how it works in your hands, and that is the only thing. This is a patient who had 24 surgeries for a congenital malformation by various people who thought they had good intentions. So Samuel Johnson said, the pathway to hell is paved with good intentions. Good intentions don't matter. What matters is if you're on the right track and if you're doing the right thing. Thank you very much.
Thank you, Dr. Mamoon, for an excellent presentation on lymphedema management, which I think most of us, when the patient walks into our clinics, we just wish that, this patient never came to us. The answer to these patients are always very difficult and very lengthy. Okay, so now I'll open the floor for any question, answers, and panel discussion.
So for questions, I would like that whoever wants to ask the question can come forward, point out or identify to whom, which speaker you want to address your question, and make your question shorter and crisp so that we can have more questions. Can you give him the mic? Okay, so I think let's start with Dr. Chowsky and then...
Just one question to the first speaker. For thrombolysis, do you have an age limit that you sort of don't intervene from?
I think it's not the age limit, it's the functional status of the patient. I mean, if you have got an 80-year-old who is walking 5 miles a day, and if he has stopped walking, I think if he has got no other comorbidities, probably we will still do it. It's like the aortas. I mean, if you have good life expectancy, then you proceed with the treatment. But I don't think we can draw a cutoff in terms of a younger patient or an older patient. I think it is a gray area, but it is decided based on the patient's performance status, also the multidisciplinary decision in terms of if everyone agrees, I mean, one more thing which we did was we started a venous MDT at that time when we started this service. So, and I think that really helped us because we had acute medical physicians, we had hematologists, vascular surgeons, and interventional radiologists, and that kind of really helped us in terms of making these decisions. And sometimes patients want it, but you don't want to do it. So, I'm coming back to your question. I think it's the patient we're treating, not the age.
Is it not true that the elderly patients are more prone to bleeding? So even though there may be performance status might be good, the bleeding risk is obviously quite high. Do you
I think now we have mechanical thrombectomy devices available. So it's the clot removal is the aim. So if you can remove the clot burden and if you can establish the flow, then yes. Again, is patient selection will be not offered to people who are more prone to bleeding. If you're doing mechanical thrombectomy, yes. But if you're doing a mechanical thrombectomy, then obviously you can proceed.
Okay, thank you very much. We'll have the was it Farid?
Yeah, Farid, you have a question? Yeah.
Thank you very much. So my question is again for Dr. Abdullah. So given the fact that May Turner patients are mostly young patients, and we understand stenting is the way forward, so we have to stent those anyway. So what are, in your experience, the results of stent in long term? So how commonly we see re-stenosis or occlusion of those stents, say 5-10 years down the line?
Unfortunately, I mean, we do not have a long-term data on these cases. Personal experience for the last 8 years, the stents that have occluded are the ones which occluded within the first week. So, I mean, I have seen patients which were stented back in 2016, 2017, and the stents are still patent. If you oversize the stent, they do develop a little rim of thrombus or in-stent thrombus around it, but they still remain patent if the patient is actively mobile. But if it's coming back to the learning point again, I think it's the inflow that matters. If you have got good inflow vessels, then you will get good long-term patency. And I think that's how we kind of evolved. We initially were doing it. Initially, when it started, everyone wanted to do the stents, but then once we had a couple of patients who did not do well, and again, learning from experience, I mean, I think I went to Jerry O'Sullivan in Northern Ireland when I started doing it, and he had done fair few by that time, and I think I learned from his experience a lot. So crossing the inguinal ligament, going into the leg veins. I think yes, we want to be the heroes, but I think you have to choose your patients wisely. And even if you have done CDT and mechanical thrombectomy, and you feel that this patient is not going to have good inflow afterwards, we have abandoned cases, and I think that has helped us in the long term because then you've not left a patient with a stent which is occluded. So then they go back to the conservative anticoagulation and compression stockings.
Just one, yeah.
I just want to add a little bit in this, what Dr. Abdullah said. I worked with Jerry O'Sullivan as well when I was in Galway, and he's a big name in the venous intervention. I think that the key is you put the stent from the normal to normal. That's the, and the size is very important. And the role of IVUS is really, really important. If you use all these modalities, these stents, I think, work very well.
Just one last comment or question, Dr. Makhdoumi, if you want to add it.
Just another question for Dr. Abdullah. It's just that you mentioned about how to investigate the patients and to before you start treating these patients, and you mentioned duplex scan. I mean, yes, duplex scan is the first modality, but in my experience, unless you do a CT venogram and see how far the thrombus is extending into the IVC, obviously you won't be able to decide about the filter and also how to approach it.
I don't think I said that we only do a duplex scan. I think I said initial diagnosis is made by the duplex scan. Once we were planning treatment, we are doing a CT venogram, and our protocol was we were doing a CTPA at the same time. So we know that if there is a pulmonary embolism before we have started, or have we caused one. So, and also it helps to decide if you want to do a filter or not, because if the thrombus has propagated into the IVC, then you have to have some sort of filtration. Again, I mean, coming back to the filters, if you put one, you always should have a plan to remove it, because otherwise they will, in the long term, occlude the IVC. But yes, any patient that requires treatment, we were doing a CT venogram and a CTPA.
Thank you, all the presenters and the questions. So if I can request our chairs to have a concluding remarks for this session. Thank you.
So that was a very interesting session, very varied and extremely high quality presentations. I think we have got a much better understanding now of in terms of management of DVTs and which patients would benefit from thrombolysis. Also got a very good idea of how to formulate the guidelines, which I think is really quite important to do that for Pakistan. I think the talk on recurrent varicose veins was also very interesting, and it does show the recurrence pattern. And I think in UK it's a very similar thing as well, that a lot of the patients don't have adequate initial assessment, and I think the role of assessment is extremely important. And finally, we all found the talk on lymphedema absolutely fascinating. And as has been mentioned before, these patients are often very poorly managed and just put in compression and given sort of manual lymphatic drainage. But the talk today really did, open up the mind about what surgical options there are to reconstruct the lymphatic system. So thank you very, very much for all the speakers. There were fantastic presentations, and thank you very much for the audience.
So this concludes our first session of first PAKVESCON, and now I would like to call Dr. Zia on the stage to introduce to the next session.